Xin lỗi bác Tina vì đổi tên trong giấy không đổi. Các bệnh truyền nhiễm mới nổi và cập nhật tiêm chủng trong thai kỳ, chỉ định chống chỉ định và vaccine mới. Xin mời Martina.
So first of all, thank you very much for giving me the opportunity to present about this subject I'm very passionate about. And I hope that by the end of my presentation I will convince all of you to do screening for preeclampsia for your patient and give them the appropriate prevention treatment. So I think I don't have to convince you about the fact that preeclampsia is a very relevant disease and it causes maternal death and fetal newborn death, thousands of them everywhere around the world every year. So it's very important, first of all, to predict, because to prevent we have to select a group of patients that are high risk and to whom we can give the proper prevention treatment. So historically, the way to predict the high-risk group patient has been to maternal history. So basically you have some questions to your patient. If they answer yes to a few of these questions, they are high-risk group, and if they say no, then they are low risk. This is very simple. You just ask questions, but the problem is that it's not very good quality and it's not very effective. You can pick up only about 40% of the high-risk people that will really develop preeclampsia. So Professor Nicolai's group in the Fetal Medicine Foundation came with a new method for screening, and it's kind of a triple test. It's based on maternal history, of course, as before, but then it adds a few new elements, and one is the measurement of the Doppler PI, maternal blood pressure, and maternal biochemistry. If you combine all these elements together, now you pass from a detection rate of 40% to up to 90%. So you pick up almost all cases of very severe preterm preeclampsia. You're not so good, though, in picking up the high-risk group for term preeclampsia. This is an important distinction, and we will see why later. I want to put up this slide. It's important because then, of course, this method of screening has been reproduced also in the Asian population, so it can perfectly be used by all of you in your daily practice. Regarding the discussion about PLGF and PAPE, at the beginning PAPE was used because it's already part of the double test that everybody does for our patients. And so we thought about, well, let's use the same measurement so we don't have to add anything from what we do. But then PLGF actually perform better. So if you have the possibility, you can ask to add this test and the screening perform a bit better. But it's not necessary, so you can still go up and do a good screening, even without PLGF. So these are the numbers. So just by asking some questions, taking blood pressure, and measuring the PI, you already can pick up 83% of the patient that will develop the severe preterm preeclampsia. And if you add PLGF, of course you can go up to 90%. But again, PLGF is not necessary. So if you don't have that available in your clinic, in your practice, you can still perform the screening. And it's better than nothing. So how to do that? Very simple. Go to the FMF website, you go to calculators, and then you have prediction of risk, and you go to 11-14 weeks, and you will have this screen will appear. You put all the information that you have, of course, at least maternal characteristics you should have, and the maternal blood pressure. I'm sure that all the ultrasound doctor here, I'm very confident in your ultrasound skill that you can take the Doppler PI of the uterine arteries, and then if you have PLGF or PAPE, you can add that, but again, it's not necessary. And then you calculate the risk, and then the program will give you the risk for preterm preeclampsia, okay? Now we know we have the screening. It's easy, simple, it's for free, you don't need to do anything fancy. What to do once you get the patient that are really high risk. So let's talk about the prevention. First of all, let's talk about what doesn't work, okay? So bed rest doesn't work. Salt intake restriction doesn't work. And supplements do not work. So they may be very good for other reasons, but do not advise this to your patient to prevent preeclampsia. I want to talk a little bit about calcium supplements because there's been a lot of discussion about that, and maybe there's been some misunderstanding. The problem came from a Cochrane review, a meta-analysis that states that calcium supplement can be beneficial in patients to prevent the development of preeclampsia. And this led to WHO's recommendation to implement this calcium supplementation. The issue is that if we look at the single studies that made up the meta-analysis, actually the two biggest studies, the first two are the biggest studies, and they contribute to about 80% of all the patients of the meta-analysis, and they do not prove any reduction in the preeclampsia. And then there is a series of really small biased studies that altered the result in favor of a reduction. The problem is that if you, from a statistical point of view, if you calculate the heterogeneity of all the studies, it's too high, and the meta-analysis should not have been performed. So overall, the conclusion from the data, if we look at them in the correct way, is that calcium does not prevent preeclampsia. So please do not suggest that to the patients. Let's talk now about aspirin. The history of aspirin is very long and also a bit complicated because similarly, decades ago there has been a study where it was proven that if we give aspirin early and more than at 150 milligrams, that will prevent preeclampsia. And then subsequently, there's been more studies that did not really apply what the first study said and started giving aspirin at different gestational age, different dosage, and again, didn't prove any success. But the problem was that the dose and the timing were not correct. So for many years, this caused some problem in the discussion around aspirin because meta-analyses were done and didn't prove any effect. But again, the problem was the dose and the timing. So finally, Professor Nicolaides from the Fetal Medicine Foundation arrived and decided to do a proper study, and he reproduced what was being done in the historical one and started giving aspirin 150 milligrams at 12 weeks in the high-risk group patient. And now the magic happened, and you see the real big reduction in especially the severe preterm preeclampsia before 32 weeks. Almost disappeared, okay? Was not very good, successful with the term one, but we will have a solution for that later. So again, this is again to remind you that the timing and the dose are important. So you can see the only combination that is really effective is less than 16 weeks and more than 100 milligrams. If you start playing around with timing and dose, you will not get the same results. And some patients will say, some doctors will still say, okay, maybe the results are not so good, but maybe I can still help a little bit, why not? And this is why not. Because these are the incidence of placental abruption and antepartum hemorrhage according to the dose and timing of aspirin. What happened, look at the last line, if you give more than 100 milligrams after 16 weeks, it's not only that you don't help your patient, but you double the risk for placental abruption and antepartum hemorrhage. So not only no benefit, but actually harm. So to summarize, preterm preeclampsia, we have a good prediction screening method, and we have a good preventive treatment, and you have excellent results. More than 100 milligrams, less than 16 weeks. Now let's talk about term preeclampsia, because we say that the prediction model was not very good for the term preeclampsia, and that the prevention also. Why talk about term preeclampsia? Is it a real issue? We all think that the one that is bad is the preterm, is the one that causes the most problems in our patient and baby. It's true, but because term preeclampsia is so much more prevalent, then overall most of the contribution of term preeclampsia to adverse outcome is much higher. So just because the term preeclampsia is much more frequent, it's actually even more relevant. So for the screening, again, for prediction, very similar model. We use the history, we use the Doppler in the uterine artery, we measure the blood pressure in the mother, we use the biochemistry, and if we do that, at 12 weeks, it doesn't work. At 22 weeks, it doesn't work. But if we approach 32, 36 weeks, then we start having a prediction model that is really good. So the problem is that if we look too early in the pregnancy, we cannot define the high-risk group. But if we start looking closer to the end of the pregnancy, then we can have a good prediction. Same thing as before, you go to the FMF website, calculation, prediction of risk, and now you go to 30 to 37 weeks. So when your patient comes for the third trimester scan, that I know we all do here, you can calculate and predict her risk for having preeclampsia. So again, you put the measurement. What measurement? History, easy, everybody can do that. Measure blood pressure, we all know how to do that. When you get to 32 weeks, Doppler PI is still useful. At 36, if you have PLGF and S-fleet, uterine Dopplers are less important. But still, if you don't have the biochemistry, use the Doppler. I'm confident in your ability, you will know how to do that. Now that we have the prediction, we know that it works, we know how to do that, so we can easily implement that, what to do when we have the high-risk patient. So, trial on parvastatin for prevention of term preeclampsia show that it doesn't work. Okay, so all other trial for all other medications do not work. And that's why a new idea came into play, and is that, well, now we are at term, and we know that what is the definitive treatment for preeclampsia? Delivery. And now we are at term, so we don't have to worry about the baby anymore because he's a term baby. So why don't consider delivery as the prevention for preeclampsia? If you know that your patient is going to develop preeclampsia very soon, you deliver her today and she will not develop preeclampsia. So this is the rationale for the new ongoing trial at the Fetal Medicine Foundation, is to screen all the patients at 36 weeks for risk of preeclampsia and then divide them in group. If they are very high risk, intermediate, low risk, and very low risk, and time the delivery according to the results. So 37, 38, 39, 14, 41. And hopefully this will lead to a reduction of 60% of the term preeclampsia. So this is still ongoing. We have to wait for the result, hopefully 1 year, 2 years. So stay updated because result will come, and this appears to be a good way to go. So just for a general summary, we have two main things, preterm and term preeclampsia. Preterm, more severe but more rare. We can screen for that at 12 weeks. We have excellent method of screening, and the prevention for the high-risk patient is aspirin more than 100 milligrams, less than 16 weeks. If you are above 16 weeks for any reason, don't start aspirin, okay? And just follow up more closely with the blood pressure and try to pick up the problem if it appears. For term preeclampsia, we have to screen closer to the term, so 36 weeks. At 36 weeks, same screening, you use history, maternal blood pressure, use the biochemistry that you have. If you don't have the biochemistry, use the Dopplers. And then for now, we can only define the high-risk people and patients and try to follow them closely. Soon we will have the results and we will see if we can time the delivery according to that. Thank you very much for your attention.
Xin cảm ơn bài báo cáo về dự đoán nguy cơ và dự phòng tiền sản dật của bác sĩ Martina Danapino. Và tiếp theo, xin giới thiệu với quý thầy cô và quý khán giả cái báo cáo về MIF trong thực hành lâm sàng sản phụ khoa do Phó Giáo sư Tiến sĩ Bác sĩ Phạm Bá Nha trình bày.